cancer. So you can't do that, and it's got to be an element of the sort of balance. The doctor has to think in its own skill and experience, and you have to sort of. I'm a bit sympathetic to the GP from that point of view, and that something happens. Such things happen quite frequently. But of course, there are some symptoms like ongoing headache more in the mornings and sickness and all that. If you have that, then doctors are obliged to send for further scanning. But I'm sorry that happens unfortunately quite commonly. But I don't see the way around it. You can't screen, you can't scan the whole population.
No, you're absolutely right. I think the resources are quite limited, and you have to sort of select those patients.
Yes. It's not justified because the more you scan, radiation is also one of the risk factors for cancer. So you can damage the gene that can cause cancer. You're not justified to use X-rays without any good reason.
If I'm not mistaken, I think GPs have a 2-way read system. Can you tell us perhaps?
That's right. That's once the GP decides to refer the patient.
Yes.
And the GP won't refer the patient unless they suspect they have cancer.
Okay.
Going back to the question, it is unacceptable, I think, to wait a year with symptoms. And I think that's never acceptable. And one of the simple golden rules, I think, is that anybody with persistent symptoms, whatever they are, should go and see the GP. And then the other thing is, I think, because these things are complex and symptoms are subtle, and poor old GP can't know every specific symptom for every cancer, because there are lots of cancers. And I think the answer is to have internet-based decision support produced by professional people who are like neurosurgeons on the symptoms when they want to see the patient. And I would guess most neurosurgeons will say if you've had even a headache with no specific symptoms, say more than 3 months, you should see your doctor, GP, and the GP should be encouraged to refer them, and we should provide the resources necessary. But you're absolutely right, the big problem with the health service, it's got limited resources, there's only one cake, and if you spend it in one way, you won't be able to spend it in another way. And if we did scans on everybody with headaches, the people with serious disease wouldn't get in. They'd be queuing. So there has to be some selection. But what the answer to the question is, we need to select better, and we need better advice.
I guess what you're saying is that people that have perhaps non-specific symptoms and that persist, then they should be seeing their GP and hoping that they get referred. And I guess those that are perhaps coming in with more sort of specific symptoms, let's say coughing up blood, coughing, shortness of breath, then those are sorts of guys that perhaps should be referred with the 2-week wait.
We have a Mr. Kumar on the telephone. Hi, good morning.
Good morning to you. I just want to know, what does the panel think about the fact that in this country there is some sort of a quota given to GPs on how many patients they can refer? I believe that is actually what stops GPs, because in a way it works against them financially. What's your comments?
Thank you for the call, Mr. Kumar. That's a very interesting question. It relates to how GPs refer and whether they refer enough and perhaps not enough, and whether there's any financial implications when they make their decisions. Gentlemen?
I'm not aware of a limit to quota to that, so I'm sorry. Maybe there is, I don't know.
I think it's a reflection of a problem that, for instance, they've recently looked at referral rates from GPs for the 2-week rule, and they vary from some GPs who refer 0.2% to some GPs who refer 20%. And clearly that can't be right for everybody. Either somebody's sending too many or somebody's sending too few. And almost certainly the truth will be somewhere in the middle. And again, I think GPs need internet decision support to help them select out the patients they should be sending. So in terms of your actual question, I think in principle it's wrong. I'm a great believer in clinical freedom. And to some extent, we have to trust our GPs to make the right decisions. And I think it isn't always just a matter of risk either. If the patient's really worried and anxious, they need referring for reassurance. So I think quotas are dangerous. I can see why it's happening, and there's a good reason, a good basis for it. It's credible. But I think it's a bit of a slippery slope. And obviously, it's GPs to answer that question, not specialists in hospitals. But I feel sorry for you. I think it's difficult.
The reason that sounds implausible is that GPs have different size of catchment area, and incidence can slightly vary. In London, especially, you have different ethnicity in different parts of London, and cancers do vary with ethnicity as well. So I think that I wouldn't think that that was a rule to have a fixed quota for the GP surgery to refer a certain number of people only. You can't refer beyond that. I'm not aware of that. Maybe you could have a look into this and find out perhaps.
Okay, panel, we'll come back to you in terms of more questions and more calls. It's time for the question of the week, and we'll just play a short clip for that.
My name is Aisha, Angel Promotion. I just want to know the cause of sickle cell in this country.
Well, thanks very much for that. So this week's question of the week is regarding sickle cell. I mean, in terms of, what's your views on the incidence and the prevalence of sickle cell in the UK, Dr Mirza? Slightly not related to your specialty field.
It's not a cancer blood. Don't do with blood. I'm sorry, I don't know if I can answer that with any authority. Of course, we know it's to do with genetics, and there's a certain type of gene that sort of has signals about the hemoglobin, the type of hemoglobin you have, and if people have a combination of two abnormal genes, then they have sickle cell disease. If they just have one of them, it's sickle cell trait. But I mean, it's more common in African population in this country. Beyond that, I'm afraid I can't answer that in great detail.
Yeah, thanks very much. Yeah,
thank you.
So it is a bloodborne condition, and it is genetically related, quite common in African populations, and it does have significant implications in causing symptoms such as pain and different other crises involving the chest. If any of you are suspected to have sickle cell or are aware of any relatives that may have sickle cell, then we'd be advising you to see your GP for further information. We have a Sister Saima on the telephone at the moment, so we'll just go to her. Assalamu alaikum, Sister Saima.
Walaikum assalam. Basically, I got...
Fire away, sister.
Yeah, basically, I got a question. I had symptoms for last couple of months. Basically, before I was suffering with the migraine for a long time, about 15 years now, and now specifically I start getting the headache on the back of my head, and they're really bad. I can't even describe how bad it is. And usually, like when it starts, I can't talk. My cheeks start hurting. My tongue start having a funny feeling. And I don't know what to do. Like, I've spoke to the doctor once or twice over the phone. They go, it's just a migraine. But I think I'm quite familiar with the migraine headaches now. But this kind of headaches is quite bad. I can't even describe what kind. It's really painful. Just so.
Sister Saima, what are you worried about? What this symptom could be due to?
I don't know. Like, it's just back of my head. And it's quite painful. Like I can't do anything when the headache starts.
Okay. Well,
thank you very much for your call, sister. Gentlemen, very briefly, we're coming towards the end of the show. Any suggestions?
People learn to recognize the symptom. And migraine is generally a condition which sort of has similar symptoms throughout. It doesn't change much. So I think if the nature of pain has changed, and she's describing more towards the back of the head rather than on one-sided, and then I think she should. I don't know if you've seen the GP about that, or you just spoke on the phone. Perhaps it's just worth seeing a GP about that, I would have thought.
Okay, well, thank you very much. I mean, we are coming very quickly to the end of the show, but could we just briefly wrap up with 3 main key points from today's show on cancer? Mike?
We've already talked about a healthy diet. Lots of exercise, and this will be not only good for cancer, it'll be good for your heart and your chest, and it's very sensible and it's very nice. So a high roughage diet, I think, is a good thing to go for.
Good. Anything else, Dr. Mirza, very briefly?
I would add screening.
Yes.
I would also say people have fear about this cancer, and then they think it's sentenced to death, which is not the reality. 50% of cancers, including skin cancer, of course, are curable.
Okay.
So there's cure out there, and then you must reach out for it.
Okay, unfortunately, guys, that's all the time we have for today's show. I'd like to give a massive thanks to our guests, Mr. Mike Thompson, consultant surgeon, and Dr. Mirza, specialist registrar in oncology.
Thank you very much, guys. Now, next week, I'll be joining you with Dr. Majid on our show on allergies. So do keep tuned in.
Assalamu alaikum.